Huo is going to present his solution. Dr. Huo, please.
Yeah, can you hear me?
Very well, please, go ahead.
Okay, thank you. This is Yu Long from Shanghai Jiao Tong University. Thank you for the invitation. So I have the opportunity to show my results. Today, my topic is caFFR validation and clinical data. I'm from RainMed because we built up the RainMed. We built differentiated product portfolios, so we define the modulars. For example, the digital functional diagnostic model or the automatic interventional model, and clinical applications around the vascular intervention surgical robot system. We have already have the robot system as shown in the right figure. And we automated the process of the PCI, including the diagnosis and the treatment. Today, I will introduce the caFFR system in the digital functional diagnostic model. We know the degree of the stenosis is unequal to the degree of myocardial ischemia. So FFR is a much better ways to diagnose myocardial ischemia. So we propose our caFFR system. Our system needs two parts. One part is our pressure sensor, we call the flash pressure. Another part is our machine. Our machine is we don't need for the wear manipulation. For example, like the Abbott, the pressure wear. We don't need the hyperemia stimulus, and our CFD model can save time significantly. We can reduce operational risks. The basic principles is we get the angiogram from two projections. This one we can get the length of the we can get the length of the coronary arterial trace. And then we use a TME method to get the blood velocity. And we monitor the real-time aortic pressure waveforms. And then we use our optimized computational fluid dynamic model to calculate the pressure difference from the inlet to the distal positions. And then we can use a caFFR equation to calculate the caFFR. We call the caFFR is a coronary angiography derived FFR. Our total operational time is smaller than 5 minutes. About 10 years ago, I found that the flow velocity has an effect on the FFR. Maybe it can occupy the 35%. The diameter. The minimum diameter has a maybe 45% effects on the FFR, and also the inlet blood, also the aortic blood pressure and the length of the blood vessel, as well as the inlet and the outlet diameter, has almost 20 to 30% effect on the FFR. So the best way to determine the FFR using the CFD model, but a traditional CFD model need at least half hour. That means 30 minutes. We use our optimized CFD model. We can reduce the time to 30 seconds. This one because we have our own database. Also, we use some AI method to reduce the computational time, so we call the optimized CFD model. But if we include maybe the angiography and also other part, totally our operational time is smaller than 5 minutes. In 2018, we finished our clinical trials. We have the 328 patients we evaluate diagnostic performance of caFFR compared with the word-based invasive FFR. The bottom part, the left table shows basic characteristics. For example, we have the 328 patients, and the LAD, LCX, and RCA has maybe 59, 11, and 26%. Also, we include the bifurcation lesions and calcified lesions. Our diagnostic characteristic of online caFFR, the accuracy is about 95%, is 95.7%. This one is fast. If we do the PPS, our accuracy is higher than 96%. Our offline caFFR diagnostics is very similar to the online caFFR. So our caFFR has a high reproducibility. Also, we have the left figure shows the correlation between the caFFR and the word-based FFR. From this figure, you can find there is a good correlation between caFFR and the word-based FFR. At present, we propose another clinical trials. We call the FLASH2. This clinical trials, is a prospective multi-center blended random this trial compared the caFFR and FFR in guiding PCI for patients with moderate coronary artery stenosis. We have already registered close to 800 patients, but estimate the total number of patients will be 2,132 patients in over 40 centers in China. And this one, we will get maybe after 12 months follow-up, we will determine if the caFFR will produce non-inferior clinical effects and cost benefits in comparison with word-based FFR. We hope we finish these clinical trials at the end of next year. Summary for the caFFR, in my point of view, I think we have the high accuracy and prognostic value, and we don't need the wire manipulation and additional surgery. We don't need the hyperemia stimulus, and it's a real-time FFR. But we still have some limitation. For example, the ostium lesion and very deep myocardial bridge will affect the accuracy of the lesion diagnosis. Finally, thank you.
Thank you very much, and we'll move to our next online speaker. Welcome back, Professor Tu, and we'll take the questions